Hello everyone, welcome to Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm Dr. Angela Mattke, and I'm the host of Ask the Mayo Mom. I'm also a pediatrician at the Mayo Clinic Children's Center in Rochester, Minnesota. Every couple weeks, I host a show about pediatric health topics and answer your questions live. What makes this show so much fun are the interactions and questions we get from you, the live Facebook audience. So please send in relevant questions today regarding our topic, which is inflammatory bowel disease in children and adolescents. To help me discuss this topic today, my guest with me is Dr. Jeanne Tung. Dr. Tung is an assistant professor of pediatrics and a pediatric gastroenterologist at the Mayo Clinic Children's Center. She subspecializes in the treatment of inflammatory bowel disease in children. You can follow Dr. Tung on social media for updates on inflammatory bowel disease by searching her on Twitter with her handle at JeanneTungMD or on Mayo Clinic's IBD blog, which is ibdblog.mayoclinic.org for updates on latest research and treatments for inflammatory bowel disease. So thank you so much for joining me today, Dr. Tung. I'm excited to have you here today.
I'm absolutely thrilled to be here.
Awesome. I know you have a busy schedule, so we appreciate you coming and
Absolutely.
taking time out. Let's get started by talking about just what is inflammatory bowel disease so we can set the topic of getting into more specific questions later.
So inflammatory bowel disease is essentially an autoimmune condition. There are a number of autoimmune conditions out there. A lot of people may understand diabetes or thyroid or rheumatoid arthritis. Even psoriasis is actually autoimmune, where the body's immune system has, I often describe it as sort of gone awry. Instead of fighting infections, it's actually attacking your own body. And so in the sense of inflammatory bowel disease, it's attacking your gut. And there's sort of what we may say is two types or two flavors, where ulcerative colitis will affect just your colon, and Crohn's can affect anywhere from your esophagus down to your colon. One of the major things I should probably start off saying is one of the big confusing things is, I don't know why they named it that way, but irritable bowel syndrome is not the same thing. It is still a GI condition. You unfortunately could have both, but why they made it so confusing is beyond me. But
the IBD
it's very
and IBS,
different.
those very similar acronyms. So how does IBD in children present? What are the common ages for it as well?
Yeah, so I know when I first started training, it was something along the lines of somebody who was in junior high school or high school years. About 1/5 of all people will be diagnosed as children in the United States. And so what was usually typical was diarrhea, bloody diarrhea, cramping, fatigue because you ended up being anemic from blood loss. But what we have also recognized is that, especially for something like Crohn's, you may just show up as having some degree of cramping. You won't necessarily have the diarrhea. And we also know that you may also have growth issues, so weight loss, but actually, they're falling behind with the rest of their class. And so that's what we're seeing as well.
Absolutely. As a pediatrician, that's, one thing that's always on my mind as I see a child who's having difficulty gaining weight, or we're seeing difficulty gaining weight and their height is starting to be affected. So that's something we start thinking of, even if they're not showing those overt symptoms that you see with inflammatory bowel disease.
Exactly. And that's something that we emphasize with our trainees as well, is making sure that you're looking at the growth charts as well.
Absolutely. So how does IBD in children compare to IBD symptoms in adults? You mentioned about 1/5 of kids or people will get it.
I think the growth is really what we see as being different compared to the adults. One thing that has become of strong interest amongst some pediatric inflammatory bowel disease specialists is this concept of what we call very early onset IBD. And so I mentioned that we're used to sort of seeing these junior high school, maybe 10 and above, and now we're seeing 10 and under, 5 or 6 and under. And those are certainly more worrisome, because we weren't really expecting that. We're usually thinking about maybe some infections or food allergies or something like that instead in those children. And so it's a bit of a surprise when we think that we're seeing actually IBD. So I think that it certainly can be concerning for parents. It's concerning for specialists because we're still, trying to understand this. And there are segments of our IBD physicians out there that are actually starting to learn this, study it, and they're actually finding genes that may be specific to that particular condition.
Just the very early onset condition?
Yeah, exactly. So, I mean, there's well over 100, probably approaching 200 genes that are found in IBD now, which is just amazing. A lot of them have to do, as you can imagine, with our immune system and how that interacts with our gut and maybe even the environment. So there may be differences in these early onsets compared to what we're already appreciating in older children or adults.
Okay.
So.
You said it typically, in your early training, it was more junior high, and now you're seeing these earlier onset. Is the thought that this is a new thing that's occurring, or is it maybe that these children weren't diagnosed and they were always there and they were just being missed earlier?
I think it's a mix. I think we may be picking them up a little bit better. Some of these children it's not just a little bit of bloody diarrhea, it's pretty profound. Wow. And we are actually seeing some what we call perianal disease, where you actually have something different. And I don't think we're missing those per se. That's much more obvious. I think for reasons that we're also trying to appreciate, there is just more autoimmune disease now compared to prior decades, and that's a huge question that we're still trying to answer as to why it might be happening more often. So.
We have a great question coming in from the audience, and it says, how severe should symptoms be in a child before needing to pursue a medical evaluation and confirm the diagnosis? And they're also wondering if there's a family member who has Crohn's disease, would that prompt a more earlier evaluation?
Yeah. I can absolutely imagine that any parent who has Crohn's or their spouse has Crohn's is always going to be much more heightened about their children. So I think it's going to be a little bit challenging because you don't necessarily want to react to every bout of abdominal pain or cramping or a little bit of fatigue. But I think you kind of just watch the pattern. As I mentioned, certainly if you start seeing growth issues, weight loss, or height, that's enough, I think, to bring it up to the pediatrician or, at those annual visits, make sure that's being looked at. The obvious sorts of things of diarrhea with or without blood in the stools, that always means that we should check for infections first. Most children don't have some drug exposure that might have caused them to have diarrhea, but that's always fair to look at the other possibilities. And I think that, I think it's always good if something's been happening for several weeks to months. It's always good to bring that to attention.
Right, as opposed to the acute, which is going to be just a couple days and kind of self-limited, so parents can watch that. So that question, I think, brought up another interesting topic. So, what is the cause of inflammatory bowel disease? You mentioned genetics a little bit.
So I think there are some diseases where if you have the gene, the one or two genes that have been discovered, you automatically get the disease. And that's just not the case with IBD. Just because you have it, or, we're not at the point that we can really explore that many genes for everybody when it's over 100 types and really think that for sure you're going to get it. If you have IBD yourself, the chances of passing it down are something like only 5 to 15%, if that. If you have two parents or a twin, that risk may go up to more like 20 to 30%, maybe 40 if you've got lots of people in your family. But we certainly don't discourage people from having children if that's what they want. That's actually a very common question amongst our teenagers, actually, and young adult young women, so that's not surprising. So certainly we know genetics. To some degree, we don't really know about the environment. We know that if you've had an infection, you're going to be more likely to develop this. And I think of it as, the immune system turning on to fight the infection, and now it can't turn itself off. There may be something related to antibiotics, but that's a mixed question then because you were trying to find an infection. How much did the antibiotic additionally contribute to affecting the immune system? And everybody's very keen on investigating what the bacteria in our guts are like and how much they're contributing to that as well. So there's that. We have seen differences in food. So there's a number of things in the environment. I don't think we, unfortunately, as parents, can control everything that you're seeing. I certainly have met parents that they did everything right. Mom took very good care of herself before she even got pregnant. They breastfed. They didn't do antibiotics, excessively. They gave them organic food, and unfortunately your child could still potentially develop this. So I think it's great to live as healthy as possible, but I don't think we can, at the point that we can advise people fully what you can control.
Absolutely. There are some chronic diseases. If a family member has that disease, we automatically screen the children every so often in their well child screening. Is that the case with inflammatory bowel disease? If a parent has it, you would do routine screening for a child if they're growing well?
No, I don't think I would. I think I would still focus very much on what kind of symptoms there are. Unfortunately, there still isn't one blood test that we would fully rely on to say that this is IBD. If it's positive, you automatically have it without having to do more testing. But I think that you can be pretty good at that. if there are symptoms already there and you have anemia or signs of inflammation in your blood work, that may lead us towards, having to investigate further.
Absolutely. We had a question from the audience about a child who's been struggling with some constipation. They've been trying to treat it with some changes in their diet, but this child also has a parent who has Crohn's disease. So I think this really gets at the question, can constipation really be one of those symptoms that presents for inflammatory bowel disease?
You wouldn't think so. You would automatically think diarrhea, but no, we actually have seen, and it has been documented in the literature, that you can have some inflammation in the colon and actually be constipated. Or if more of your disease in Crohn's is in the small intestine, you don't necessarily, you can certainly have normal looking stools. So I think that it goes back to, again, see your regular doctor about treating constipation, and if you still have difficulties, then go on to see GI. But even with a parent, go back to how are they growing? Are there any other signs that could be concerning? And I should say that things that we sometimes might see that would be less common but not rare would be, we may talk about having lots of mouth ulcers. Not just a little mouth sore thing, but maybe something more often than that. Joint pains that you think aren't just because they were, playing at a basketball tournament, but joint pains maybe plus or minus swelling, and there may be some skin changes that are indicative, but most pediatricians know those findings. So.
Absolutely. Well, let's move on to talking about treatment. We're getting some questions in about that, and I think that's where a lot of families really want to know what is the best. So how do you start in treating inflammatory bowel disease with a new patient?
Oh, that's a really tough question, actually. So there are some drugs that are unique to ulcerative colitis, and there are a few that are unique to Crohn's, but really there's a major overlap. We have really been finding more and more drugs that are targeted to what is going on with the immune system or what's actually wrong with the immune system. It's still at the point where we need to make a recommendation based on what type of IBD it is, how severe we think it is. So we may not start at what we call the bottom level. We may say, no, I think because you've had such growth failure, because you are so anemic, because we found so much inflammation going on, we really think that you need to hit it more aggressively up front. And over a good decade now, to be honest, we are finding more and more proof that we should arguably be more aggressive, as scary as it may be to a parent, that we are actually better off in the long run being more aggressive, taking care of the inflammation, and then maybe in the next 1, 2, 3 years saying, maybe we can back down on the therapy that you're having. One of the major things, my colleague, Dr. Ed Loftus, who's one of our adult IBD physicians, he has a great video IBD blog that he really emphasizes that as scary as some of the medications that we're using are, and when I say scary, it's because most of the time it's infections, that you might be opening yourself to more infections. There's a small risk of cancer, but as you can imagine, patients are very scared about that risk, and parents are even more so going to be scared about that risk. But the risk of cancer is very small, and what we see is that the risk of untreated IBD is much more often a problem, whether we end up being, unfortunately, growth stunted because we approach the end of puberty, maybe we have such severe anemia from the ongoing blood loss, maybe, unfortunately, we end up requiring hospitalizations with steroids or even surgeries that we're trying to avoid if possible. There's a roundabout way of saying that we don't have an individualized treatment at this time. We have more and more medications that are coming out. Every decade brings us something a little bit new in terms of new pathways of inflammation and new drugs that are targeted towards that.
There's been a lot of talk about diet. Recently there's been some publications saying that diet can effectively treat or cure inflammatory bowel disease. So what is the role that diet has in treating inflammatory bowel disease?
That's a great question. And I think we will know, hopefully in a few years, how much diet can contribute to actually treating inflammatory bowel disease. So what's really interesting is that we were talking about the gut bacteria, and so there are data that shows that, what you eat can certainly affect your gut bacteria in a healthy situation. So, if you are really enjoying some fast food restaurants all the time and that's the mainstay of what you're eating, that your gut bacteria is going to look very different than somebody who's eating, not as much red meat, low fat, low sugar, low quote processed foods, you're going to have a sort of nicer looking gut bacteria pattern. And we know that people with inflammatory bowel disease have more of what we would call a pro-inflammatory pattern. So something made that change along the way, whether it was the infections we talked about, whether it was the antibiotics we talked about, something else in the environment. So we know that there's changes that happen just simply from how your gut bacteria looks and what you ate leading to that. The tougher question is, now that you have it, what can you change about your diet that would really improve that change? And so there are sort of two classes of therapies out there. One that I do believe in strongly because there's lots of data. And that's when you're first diagnosed and when you're bad flare, it's called EEN, or exclusive enteral nutrition. And that's actually to avoid having to go through a long course of steroids. Steroids can be tough because they suppress your immune system. Teenagers and parents don't like it because you get moody, you get acne and zits, you put on weight, you get these chipmunk cheeks that are going on. So you just don't look good, you don't necessarily feel good, but it does temporarily make your gut symptoms better. But it also, not only does it affect the mood and the weight gain, but it's actually also an immune suppressant, but doesn't prevent the disease from getting worse. Whereas with this other diet therapy, where you're basically drinking formula, shakes, if you think of it that way, you're drinking that exclusively for a number of weeks. And studies have shown in the pediatric realm that it's just as good as steroids in terms of minimizing your GI symptoms, but keeping you good nutrition throughout that time, helping you gain weight, maybe even decreasing inflammatory markers that we find in the blood work. And so it's a very safe sort of thing. It's socially a little bit challenging. I shouldn't say it's just a little bit challenging. It is socially challenging because we're used to eating food, but and there are some workarounds through that. But it is a really interesting therapy that's been around for a number of years, and that some centers are more prepared in having that discussion, and also preparing patients for that. The other one that has been very hot is, as you imagine, we've heard of the paleo diet and the South Beach diet for weeks, years now for weight loss. But something called the specific carbohydrate diet was developed initially for celiac. It was sort of made up by a physician, and a patient's mom used it for her son with Crohn's, and apparently did so well that she kind of has helped popularize this. It does. Only a couple years ago, I actually was poo-pooing it, but we've had at least 2 centers have published good information in small studies. That seems to be really helpful. It is, again, challenging, but in a different way. It cuts out a lot of carbohydrates. It cuts out milk and certain types of cheeses. It cuts out essentially what you think broadly as processed foods. And so there are a lot of things that you need to be eliminating. Some patients just can't get through it to even see if it's helpful. I do worry as a pediatrician that if I have somebody who's a very picky eater, they could run into nutritional issues. And one of the things we emphasize to families is we may have we don't want to add more stress to a situation. We don't necessarily want one parent who's bought in, but the child's not willing to do it. We don't want to add something more stressful to an already difficult situation, a difficult chronic illness. So that if people want to try this, I have personally okayed this. We have some great dietitians here that are very well versed in this diet, and it's helpful to make sure that there aren't any nutritional gaps involving. So along that lines, what's really interesting moving forward is that Seattle Children's Hospital is one of the leading institutions looking at this. They have a population that's very bought into this diet and are willing to try this out. So they will be spearheading a multi-center trial trying to look at the SCD and treating Crohn's disease patients, or I should say patients with Crohn's disease. And then separately, enough patients were making an ask of the Crohn's Colitis Foundation, which is a national nonprofit organization specifically dedicated to IBD. And physicians listened, and they were actually able to get a very large NIH grant so that they will do a comparison, unfortunately in adult patients, but it's adults with IBD, will be split either to try the SCD diet or the Mediterranean diet. and they will actually have boxes of food sent to their homes so that they can be very strict in controlling what they're eating.
Wow.
And they will compare blood and stool samples to see what changes there may be. So this is what we call a pilot study. It's not necessarily truly showing a cure, but they will at least try to see what variations there may be just by being, that simple changes in diet. So I think we will know something in the next couple of years. In the meantime, as I mentioned, I will, in certain scenarios, have my patients give it a shot. I'm a little leery still of saying that they can try this only without traditional medications. But no matter what, I think that families should have trust in working with their physician, so that if you want to try this, that you set parameters of how long you're going to do this. Again, meet with a dietitian, follow the blood work, follow the weight, follow the growth, and let's see how things are going. So.
Absolutely. Well, that's really interesting. Thanks for sharing that. I've been following that on social media and have seen it trendy and on a national news site. So it's interesting to hear what the future holds for trying those trials out. So there's a lot of families that when faced with a chronic illness and stuff like that, they look to complementary or alternative medicines to see if they have some role in helping treat their child's chronic illness. For inflammatory bowel disease, what's the role for using complementary or alternative medicines?
Yeah, so that's a great question. I think some have been investigated. There still needs to be a lot more investigation. Drug trials are not easy to do, and for complementary and alternative, we in the IBD world would like to hold those to the same scientific rigor. There has been some data that curcumin, which is the active ingredient in the spice turmeric, may be somewhat helpful, but in terms of the right dosing and availability on a regular level might be challenging. It's not something you just go to your spice store and pick up some. Probiotics have been heavily studied, and it may be helpful in people with ulcerative colitis who had to go on to having surgery but having issues with what they call their pouch. But unfortunately, it has not been clearly demonstrated to be helpful in most patients. Thankfully, it's usually safe. There's been a lot of information related to vitamin D, of all things, where we know, not surprisingly, we're in Minnesota, many of us have low vitamin Ds because we don't get a lot of sun exposure and we're in a northern climate. But we do know that maybe it has to do with absorption issues, with active bowel inflammation, that you might be low. But there is information that suggests that people may actually do better by ensuring that they have adequate levels of vitamin D. I'm sure I'm forgetting a couple here and there, but unfortunately there's not a lot that have really been shown to be helpful. It's not that we aren't amenable to trying something if somebody has designed a good study. One of the things I would always emphasize, no matter what chronic illness you have or what disease condition you have, I think it's always helpful to make sure you're having a very open and honest discussion with your physician about what you're taking, because some medications, for instance, aloe is something that somebody asks about frequently. Aloe, I think, is great for the skin, maybe moisturizing, maybe healing some cuts and whatnot, but in the gut, it actually can cause diarrhea. It may actually cause ulcers, depending on how good this quality that you might be buying, and it may actually affect your steroid levels. There are some medications out there that can counteract what you're trying to do with your own medications, and there may just be safety issues. And so it's always helpful to make sure you're having that discussion of, do you think this is safe? Can we combine it? We may not know all the information out there because complementary medicine, many of the supplements you're taking are not FDA regulated. So we may not be absolutely certain what you're taking. What you think you're taking is what you're taking, much less the dose, much less any other additives that are in there. So we have to be careful. But I think being open on our end as physicians is just as equally important.
Absolutely. Along the lines of the alternative medicines, one thing that you probably are asked a lot in the office is about, does medical marijuana have a role in helping treat inflammatory bowel disease?
That's a great question, and it's something that was just asked about at a recent patient education conference, and last month I had a conversation in my office as well. So there seems to be some theoretical benefit from medical marijuana in terms of decreasing inflammation. There was a study several years ago in Israel where that formulation was actually, they were managing to grow flowers, the marijuana plant, that was not THC active, so wouldn't necessarily cause the psychoactive benefits, but maybe still have the anti-inflammatory benefits. Over the course of the study, unfortunately, it didn't meet what they call their primary aims. It didn't really decrease the inflammation as would have hoped and expected. So we don't have good data, unfortunately, that says, yeah, it really will treat and decrease the inflammation related to my gut. In the state of Minnesota, oral marijuana is what we have as medical marijuana. Through our dispensaries, and that got an approval for Crohn's disease, but only for pain related to Crohn's disease. So I know that several of my adult colleagues are on the list of physicians who are willing to state that their patients have Crohn's, so that if they still have pain despite regular treatments, and that's what I would emphasize, is make sure that if you're having pain, make sure that there's active inflammation that we should be treating. You know, if you have irritable bowel, where we started this conversation, if you have irritable bowel and you have cramping with that, well, maybe you need some traditional pain medications first. And if there is still trouble, then perhaps it's okay to have marijuana in the situations. I, as a pediatric physician, am still really leery, since I just mentioned that we don't really have great evidence that it's going to decrease inflammation in Crohn's, but there is evidence where we have concern about what marijuana does to the developing teenage brain, whether it has to do not just with motivation, but really how well your what we call executive function, how well you process information, how well you control your emotion, how well you, maybe reaction times when you're out driving, for all those different things where, you know, I really get leery about saying that marijuana, whether it's the physician's, with the physician's knowledge and okay or not, is really acceptable at this time. So I really would want to know that there's some formulation that has been demonstrating so much more benefit than any risk that we can perceive in the teenage brain.
Absolutely. I think that's the general consensus among physicians in treatment of all kind of chronic illnesses, especially in children.
Yeah.
So let's move on. We have some questions about the evaluation and of inflammatory bowel disease. So if a patient was coming into you for kind of a potential new diagnosis of inflammatory bowel disease, what would that evaluation look like?
Yeah, so I think when you go to your regular physician, you know, as we mentioned, the growth chart will be great. Getting blood drawn, looking for anemia, which would be low red blood cells counts, and signs of inflammation in the blood work is oftentimes a very good indication, provided there is no other reason that can be found. Once you get to the GI physician, unfortunately, the stuff that we talk about are pretty expensive and what we call invasive testing. What we insist upon then for something like ulcerative colitis or Crohn's, it's sort of an automatic colonoscopy. So, you know, most adults don't like their colonoscopies, so to put a child through that, you know, it's not a small thing. But with the colonoscopy, you know, in children, we do make sure that they're nice and asleep and very comfortable. We have anesthesiologists that make sure that they are very comfortable and very safe throughout this procedure. We may often do what we call an upper scope or an EGD because, again, Crohn's can affect up in this region. So those would be standard tests for the scopes, where we're not only just looking with a camera, but we're getting tissue samples in order to look for changes that would fit a diagnosis of IBD. We often also need to look at the small intestine, and so there may be different types of radiology testing. Each institution may have different preferences, and we would do different ones based on the age of the child and what we think the child can manage. So.
Good. I have another family that's asking about if they are from an out-of-state, could they come to the Mayo Clinic for an evaluation, or are they able to self-refer for an evaluation for a child with inflammatory bowel disease?
Absolutely. I always encourage second opinions. I think it's important to get a second opinion first when you have the diagnosis to be certain that this is what it is, because it can be tricky to know. And I think that if there's a discussion about needing to ramp up therapy or even surgery, of course, I think everybody should deserve a second opinion there. So absolutely, we welcome second opinions. Oftentimes, what we like is that if you've already had these scopes that I mentioned, it's nice to make sure we have the biopsies brought to us. If you've had different CAT scans or MRIs or whatnot to look at the small intestine, any of those materials, all the lab work is nice to have as much as possible, because I just said I don't like to put kids through, things with anesthesia if we don't need to. We won't necessarily plan on repeating the studies as long as we feel like we have good information in front of us to make that assessment.
Absolutely. So, and to make those referrals by yourself, you can go on to the Mayo Clinic Children's Center website, where there's a button that says you can self-refer or request an appointment, and there's also a number that you can call, which is 1-855, and then it's Mayo Kid. So it's a nice, easy number to remember for pediatric patients. So let's move on to kind of wrapping up and talking about resources for families. So they have a new diagnosis, or they're continuing to deal with this chronic disease over time. You mentioned a couple resources before. Can you share those with us again?
Oh, absolutely.
Yeah.
I mean, local resources are always nice. Okay. Many pediatric IBD centers may have their own mental health provider in the form of a social worker using Your Child Life, psychologists. They may have support groups if they're a big enough center. The Crohn's Colitis Foundation is an absolutely amazing resource. They truly have dedicated people, both locally as well as nationally. They even have a 24/7 nurse line that if you are up at 2 a.m. worried about what's going on, you actually can reach out to somebody. But as much as possible, use your local team, talk to your doctors, talk to your nurses. They may be able to teach you a lot. We're lucky in the state of Minnesota. Our local chapter is up in the Twin Cities area, and there are some dedicated parents that created a pediatric support group. So in our state, we have several support groups for adults, but now we have a monthly pediatric support groups. And CCF has even created a network where some patients or parents have taken upon themselves to even be willing to be a phone resource for a few quick chats saying, oh my gosh, my child needs to start Remicade. What is that all about? So they really can kind of just walk you through their experiences, certainly not offering medical advice, but just being a really sympathetic ear. Because, as physicians, we may not appreciate all the nuances that a parent may be going through, but we have lots of families out there that can provide that resource. There's also another great organization that came about in the last decade called Improve Care Now, and that's a multi-center collaboration of just pediatric institutions, but not just in the U.S., but also involves England at this time. And in this organization, it's not just pediatric centers that come through with their medical people. We actually bring parents and patients. There are teenagers and young adults in their 20s that really add to what does a patient need to know? How can we help ourselves? How can we help you teach us better, provide better resources? And they've really created a strong network. And I think that it's amazing what they've pulled together, both to help the home institutions as well as this collaborative all together. And so I think they have been, to some degree, available for people to reach out.
Fantastic. And then the last resource would be at Mayo. Can you mention the blog and what kind of information it contains?
Oh, yeah, thank you. So, yes, so several years ago with our Center for Social Media here, the adult and pediatric IBD groups here started doing a variety of different video blogs. And so some of these are very basic, but a lot of what we're doing is actually sort of mentioning some new articles, new research that's coming around, and a number of us have really sub interests in IBD. So, for instance, on the adult side, maybe somebody's interested in colorectal cancers that develop from long-standing disease. One of our colleagues, Dr. Fabian, has been not only doing bench research trying to understand the inflammatory pathways, but in the last few years with our colorectal surgeons, he's working on stem cells for patients with fistulas that just won't go away. And so that's really fantastic. He's had close to 2-year results that look fantastic. And so that hopefully will be kind of channeling down the pediatric way in the next couple of years. And then my colleague, Dr. Stevens, is working with our geneticists on very early onset IBD. And so several of these video blogs are out there now for patients to kind of review. So I think that's fantastic.
It is,
Not only I go on Twitter periodically to tweet about some of these things, but one of my the best ones actually is Dr. Ed Loftus.
Okay.
He is even much more frequent on the Twitter sphere in terms of putting out new information. So
great. Well, thank you for sharing all your knowledge with us today. It was wonderful to have you here. We'll have to have you on again sometime.
Oh, I would love to
share
come
other
back.
topics.
So.
Well, thank you everyone for joining us here today about our discussion for inflammatory bowel disease. This will be archived on Mayo Clinic's YouTube channel for future viewing, as well as being available on Mayo Clinic's Facebook. My next guest in 2 weeks is Dr. Arnie Graff. He'll be here on April 20th at 10 a.m. Central Standard Time. Dr. Graff is a child abuse physician, and he's also the director of the Mayo Clinic Child Advocacy Center. He'll be joining me to discuss child abuse and prevention as we honor Child Abuse Prevention Month in April. He'll also be bringing along a special guest, his therapy dog, and the dog will be there to talk about the role of animals and showing us how they can have a powerful effect on children in stressful situations and ongoing medical care. So thank you all for joining us today. Have a wonderful day.